Okay, let's revise schizophrenia. Okay, so positive symptoms of schizophrenia. So additional things. So things that people with schizophrenia have in addition to what a kind of normal functioning person would have. So hallucinations, false sensory experiences, so seeing things, hearing things that aren't actually real. Delusions, irrational false beliefs, so believing things that aren't true, which are also associated with paranoia. Speech disorganisation, so rapid use of language, jumbling up words, there's kind of little sense to what they're saying, and another word you could use for that is word salad. Negative symptoms, so a loss of normal functioning, so they're functioning below the level that is kind of expected. So it's this idea of like failure to function adequately in terms of their abnormality. So avolition is lacking motivation, being apathetic. Speech poverty, so kind of heavily disrupted speech, long pauses, saying very little, a monotone voice, almost to the point of mutism sometimes. And alogia is another key term that you could use to describe speech poverty. And psychomotor disturbances, so lack of physical movements up to the point of being in a catatonic state. So catatonia is where someone is essentially completely unresponsive, so just not moving, not reacting to any sort of interaction. Then we have two classification systems. So the DSM is widely used in America, and then the ICD is used kind of more internationally. And both of the classification systems have kind of positive and negative symptoms. The purple are positive, the pink are the negative. The positive symptoms are required to receive a diagnosis. You need to have had the positive symptoms for 1 month. But the DSM specify that if you have negative symptoms they need to be present for 6 months. So if someone has one positive symptom and one negative symptom, the negative symptom has to be there for 6 months. Whereas it's only 1 month for all symptoms in the ICD. So that could be one reason why the ICD has kind of higher rates of diagnosis in terms of schizophrenia than the DSM does. So psychiatrists are more likely to diagnose you with schizophrenia if they're looking at the ICD than the DSM, because you only have to have the negative symptoms for 1 month with the ICD, but 6 months for the DSM. Positive symptoms are the same. Both of their classification systems require a positive symptom now. In the past, you used to be able to get diagnosed with schizophrenia with just negative symptoms using the ICD, which obviously had huge implications for the validity, because obviously you could have speech poverty and psychomotor disturbances and be diagnosed with schizophrenia. And then also the ICD obviously has more symptoms listed than the DSM. So again, that's kind of an issue in terms of more diagnosis has been made. So issues when diagnosing schizophrenia. So firstly, this idea of symptom overlap and comorbidity. So comorbidity is the idea that people suffer from 2 or more mental disorders at the same time. And this is kind of problematic because it's not that clear which disorder sometimes the person is suffering from, which is the most significant, and whether the criteria is actually allowing a valid diagnosis to be made if it's not that clear which condition they are suffering from. And part of the reason why someone may be kind of diagnosed with 2 disorders is due to symptom overlap, or the reason why they might have issues in terms of deciding which disorder to diagnose them with is because there are an overlap of symptoms. So for example, someone may have bipolar depression, and in kind of manic periods of bipolar, the person may be suffering from hallucinations, but then also in their depressive episodes they would have kind of severe abolition, potentially catatonic state, etc. Is that schizophrenia or is that bipolar disorder? It's quite difficult to distinguish between the two. So that becomes an issue because the assessments would lack validity as it's not clear where the disorder fits. How do you diagnose that disorder? And it raises questions in terms of comorbidity. Should they be diagnosed with the two disorders or just one at the same time? Or just one, sorry. Are assessments reliable? So in terms of reliability, the key issue is there consistency in the diagnosis? So is there a system that allows the different practitioners to come to the same conclusion? So when one person comes to be diagnosed, would two different practitioners diagnose that person in the same way? Would they make the same judgment? So reliability is about consistency. Are different practitioners coming to the same conclusion? And some research has found that 98%, so there's a 98% concordance rate between practitioners when using the ICD. So that means that 98% of the time, two different or more than two different practitioners would agree with the same diagnosis. So they would both agree, yes, that person has schizophrenia, no, that person doesn't have schizophrenia. So essentially by using the same criteria, they would come to the same conclusion. So that's high rates of reliability. And Sheniao found that there were low inter-rater reliability rates when they were using different classification systems. So if you had one patient and one person used the DSM, another person used the ICD, the person using the ICD would be more likely to diagnose them with schizophrenia than the person using the DSM. One reason could be because there's more symptoms. Another reason could be because the negative symptoms only have to be present for a month, whereas they're for 6 months. Historically, the previous versions of the ICD, you could be diagnosed with schizophrenia with 2 negative symptoms, no positive. So that would obviously also mean that there would be a lack of reliability because they're different criteria. And that is obviously problematic because it also relates to what we call criterion validity. So criterion validity is when the assessment doesn't allow an accurate diagnosis to be made. But in this case, because we're talking about reliability, you would say that it brings into question criterion validity because when using different classification systems, the outcome is not consistent. So therefore, adjustments essentially need to be made to ensure that practitioners are coming to the same conclusion despite using different systems. In terms of an overall for this, I would just say that there's a clear issue in terms of reliability when using different systems. So maybe psychologists should work to create a universal classification system to increase reliability. So essentially, let's merge the ICD and the DSM. Let's just use one classification system, and then there will be more rates of reliability that will increase the consistency in diagnosis at least. Are assessments valid? So essentially, improvements have been made. So previous versions of the classification systems use the term bizarre delusions, and that was problematic because it was very subjective. Like, how do you decide if someone's delusion is bizarre or just a delusion, like just not true? So by removing that, it made it more valid because it was less to do with the subjectivity, your opinion about what's bizarre, and more to do with the objective criteria. also, another thing that got removed quite recently from the ICD-10 was they also had subtypes of schizophrenia, so like paranoid schizophrenia or post-depressive episode schizophrenia. Oh no, sorry, post-schizophrenia, depression, etc. So there was like different types of schizophrenia, whereas now they don't have that, to increase the validity of the diagnosis, because it ensured that they were just categorising it as schizophrenia, not more specific types from that. So changes have been made to increase the validity. However, there are still low levels of criterion validity if different classifications cannot lead, if different classifications are not leading to a consistent diagnosis, then they can't be accurate. Because how can we have one person using the ICD saying this person has schizophrenia, and then another person using the DSM saying this person doesn't have schizophrenia? Then obviously a lack of consistency demonstrates a lack of accuracy in diagnosis, because obviously in this case you need a yes or no answer as to whether someone has a disorder or not. So assessments ultimately are not valid. So in terms of your overall, whilst there have been improvements to increase the validity, a lack of consistency across the board demonstrates that there is still not full accuracy in diagnosis, or there's still a way to go until we can confidently state that accurate diagnoses are being made. Another thing which kind of brings in, you could use here in terms of an issue with validity, is Rosenhan's study. So you could just kind of put that there. So Rosenhan and some Confederates, some little actors, went to different psychiatric institutions in America, and they said that they had, in the past week, been hearing voices. They went to be assessed. Oh my god. Sorry, something just fell in my house. 7 out of 8 of them were diagnosed with schizophrenia. All 8 of them were admitted to inpatient care. Once they'd been admitted, they said that they were no longer hearing voices and acted how they normally would. However, they remained sectioned, so remained in inpatients, kind of, kept in there for 59 days. So demonstrating that an inaccurate diagnosis had been made. So people that do not have schizophrenia, and despite acting completely normally for 2 months after a diagnosis had been made, were still kept in an institution. So obviously that was an inaccurate diagnosis. In terms of evaluating that study, because you could be asked to outline a study and then evaluate it, you could also say that this study lacks temporal validity. This would not happen now. They said that they'd only had symptoms for a week. The classification has since been updated. You now have to have symptoms for 1 month plus. And you could also say like other changes have been made, such as the bizarre delusions, etc. So that would suggest that improvements have been made to the validity of the research. Are assessments biased? So again, this brings into question the validity of assessments, because they're not accurate if they're based on bias or based on subjective judgments. So we've got this idea of women being underdiagnosed with schizophrenia because male psychiatrists perceive women's behaviour in general as psychotic. So if women are acting psychotic, they don't see that as indicative that they have a disorder. They just think that's a normal behaviour for women, which is just brilliant, isn't it? So that means that they're underdiagnosed. It's not seen as abnormal behaviour for women, and you can use the word androcentric to spice this paragraph up. And then we've got this idea of ethnocentric, so white psychiatrists have inaccurately interpreted the behaviour of black people, so black patients are much more likely to be diagnosed with schizophrenia in terms of the proportions here, rather than if you look at kind of African countries, etc., where the diagnosis is much more proportional. And then obviously you can use the term ethnocentrism and failure to take into account cultural relativism when observing behaviour. And you can use maybe examples like religion to say that potential like delusions may be seen to be based on sorry, I phrased that completely badly. Let me re-say that. So people who are religious, if the white psychiatrist is not religious, they might view that as a delusion because they don't believe that it's true. But obviously it could be a norm within their culture to follow that religion or to have that specific belief, whereas the behaviour has been inaccurately interpreted as a delusion. Oh, and then overall, yes, assessments are biased. In the future, let's recruit more black female psychiatrists, and that will improve their situation. But sorry, just keep going down the page. Can I just say with this, if a question like a 16 marker comes up on this, it's very tricky to know what they're asking. So try and get like the structure of the pack sometimes out of your head, and just think, if they've asked me about to like outline and evaluate assessment criteria, you need to outline the criteria and then evaluate it in terms of are there issues. If they've asked you to outline a study in relation to validity and evaluate the study, they're asking you to outline a study, aka Rosenhan, that talks about validity, and then evaluate whether that study still applies. If they've asked you about a study for reliability, you're using Sheniao, and then it might ask you to evaluate that. It might ask you to outline issues when diagnosing schizophrenia and then discuss those issues. So then you might say some issues are to do with symptom overlap, and that's a problem because we don't know what to diagnose them with, and then say how that brings into question reliability and validity. You might use Rosenhan in an outline, and say that like there's historically been inaccurate diagnoses made, and then you can discuss whether that's improved or not. In this kind of question, you might just think, I don't really know what my debt codes are, because you might start writing Sheniao in an outline, for example, and then you might be like, oh God, what's my debt code? But I would just say abandon debt code structure if you need to. Just make it clear with every point what you're saying. So like you're saying, this demonstrates a lack of consistency in diagnosis and therefore brings into question the reliability of the classification systems. This study demonstrates a lack of accuracy in diagnosis and therefore brings into question the validity of the diagnosis or the criterion validity of assessments, etc. So you just need to make sure you're signposting everything, like why is this here? And then your answers will be significantly better than the rest of the country. So we're all good. So as long as you understand this, you are fully prepared to answer a question on it. Just make sure you're explaining what everything shows, why everything's a problem, and then you're all good. Okay, biological explanations. So this is based on the idea that schizophrenia is hereditary. So psychologists had identified there was a pattern, but obviously families tended to have similar environmental experiences, so they did research on genes, etc., to identify the role that genes played and how significant that was. So Gottesman found a positive correlation between the number of genes a person shared with someone who had schizophrenia and their personal risk of developing the disorder. So we can see here the identical twins share 100% of their genes. So their genotype is the same. If one twin had schizophrenia, the other one had a 48% risk of developing it. So as in, if you studied 100 twins, 100 sets of twins, 48% of the pairs both had it, and then the other 52, only one of them had it. And then the risk factor decreases within, first, second, and third degree relatives. So the less genes you share, the less risk you are at. So clearly there's evidence that there's a key role that genes play, but obviously it's not 100%. The concordance rates aren't 100%, so it's not the only factor that causes people to develop the disorder, which is something you could use as an evaluation point. So it's described as polygenic, so there's more than one gene responsible for the development of the disorder. It's not one specific allele or one specific code that causes it. And it's also etiologically heterogeneous, which means that different combinations can cause the condition in different people. So it's not a kind of homogenous kind of like set way, universal across everybody who has schizophrenia. They don't all have the same specific code for that gene that causes them to have schizophrenia. RIPK, so basically what this is showing us is that there's 108 different candidate genes. So there's a specific genetic code or DNA sequence in 108 different genes that can cause schizophrenia. So it's not, there's not just one, there's loads. And this is kind of showing the different chromosomes and then the different locations on the chromosomes, and then it's showing the commonalities of the sequences for people that have schizophrenia that were different to those of the people that don't have schizophrenia. So you can see here, this long green one is a particular chromosome where in that location there was a certain genetic code that was present for obviously the majority of people that had schizophrenia, well not majority, but around 30% of people that had schizophrenia. It's not percent, significance level of 30 for those that had schizophrenia compared to people that didn't. So that is like highly involved in the developments of the disorder. And interestingly, that one there is one that codes for dopamine receptors. So interesting that the genetic and the dopamine hypothesis explanations link, because obviously your genetics inform how your neurotransmitters are balanced. So that's telling us that there are 108 different candidate genes, so genetic codes associated with the development of schizophrenia. So telling us that it is polygenic, but also showing that there is a significant difference in the genetic codes of those with schizophrenia compared to people that don't have the disorder. How significant is the genetic link? So Tainari has found that those who were born into families that had a history of schizophrenia, but then were adopted into those without, were still very likely to develop the disorder, demonstrating that there is a genetic link. But then the problem is it's quite difficult to establish cause and effect relationships when there are so many different candidate genes involved. So it's quite difficult for us to say this causes schizophrenia because there's not a gene that we can isolate and kind of test. So when you're looking at something like this, it it makes it very difficult to establish that cause and effect relationship, because there's so many different codes and sequences to consider, and the combinations can be different in different people. So it's kind of highly complex process in order to establish a cause and effect relationship. But overall, although there are many unanswered questions in terms of the specifics about the genetic link, there is definitely enough evidence to tell us that there is one, which is more useful to know that there is one, because that helps us in terms of early intervention, like understanding the risk factors. If someone goes to the doctors and says they're having symptoms of schizophrenia, the doctor can ask them, do you have a history of it? And then they're more likely to think that they need early intervention. If they do have a family history, they're more likely to develop it. Dopamine hypothesis. So make sure you define what dopamine is. So a chemical messenger, it's a neurotransmitter, which is a chemical messenger in the brain. So hyperdopaminergia is to do with high levels of dopamine. One reason could be the D2 receptors. So if you've got more receptors, then obviously you're going to receive more levels of dopamine. It could also be to do with a reduced number of dopamine metabolites, so the things that break down the dopamine. So if you've not got enough of the enzyme that's breaking down the dopamine, then obviously you're going to have more of it. And this is in the Broca's area, which is part of the subcortex, and that's responsible for speech production. And then that kind of explains why it would lead to positive symptoms of schizophrenia. So disorganized speech would make sense, but also auditory hallucinations, which is interesting. So it's the idea that often people with schizophrenia struggle to kind of distinguish between their own voice and whether they're hearing something externally or not. So it's actually the speech area of their brain that causes auditory hallucinations, which is, yeah, interesting. Hypodopaminergia, so lower levels of dopamine in the prefrontal cortex. So that's obviously a lot to do with emotional regulation, decision making, etc. And if they've got lower levels of dopamine in that area, that can lead to negative symptoms such as avolition. And that can work in the same way as kind of serotonin with depression. So the idea that there's like the reuptake happening, which is why it's not making its way to the postsynaptic cleft. Evidence to support the dopamine hypothesis. So people who do not have schizophrenia can take drugs which increase dopamine levels, so amphetamines, and that can cause them to have positive symptoms of schizophrenia. So I, as a non-schizophrenic individual, could take illegal drugs. I do not, just to clarify, but if I did, I could take the drugs and then I would start having hallucinations, etc. So that demonstrates that there is evidence to support the idea that dopamine does play a key role in causing positive symptoms. And then drug therapy does not alleviate positive symptoms in a third of patients, despite adjusting dopamine levels to normal. So essentially, even if your dopamine levels have been stabilised, you might still be having positive symptoms. So therefore, dopamine is not the only factor that could cause the symptoms. There must be something else. And then overall, you can say, like, ultimately, it may not be the only factor that causes schizophrenia, but there's enough evidence to demonstrate that dopamine does clearly play a significant role in symptoms. Or you can say, like, further research needs to be conducted into other neurotransmitters to see, like, what further chemicals can play a key role. So there are also pieces of research that suggest that glutamate and serotonin actually play a key role. Some have said that some people may have schizophrenia that's glutamatergic rather than dopaminergic and possibly serotonergic. So, like, different neurotransmitters might be more responsible in different people, or it could be to do with like the way that they react with each other, so inhibiting each other, etc., and affecting the levels. Essentially, your point is that the research is mainly looking at dopamine, but why aren't they looking into glutamate and serotonin as much? And that's kind of the direction the research is going in now. Neurocorrelates, so think correlation, think brain, certain brain structures or activity levels in parts of the brain are related to specific symptoms. So neurocorrelates are positive symptoms. So the superior temporal gyrus has a neural correlate, so a relationship with positive symptoms. So the auditory cortex, which is in the superior temporal gyrus, if you don't want to remember both, just remember one. It's probably easier to remember auditory cortex because the symptom that it's related to is auditory hallucinations. So essentially, there are lower levels of activity in the brain of there are lower levels of activity in the auditory cortex of individuals that have schizophrenia, and that can be associated with auditory hallucinations. So essentially, if that part of the brain isn't working adequately, it's not functioning adequately, then that could explain why the sufferer is having auditory hallucinations. So they're hearing things that aren't there. Secondly, the ventral striatum, so that's the kind of middly bit of the brain that is related to motivation, reward, etc. And then obviously, if there's lower levels there, that's not functioning adequately, and then that would result in negative symptoms such as abolition. So if the part of your brain that plays a key role in motivation isn't working, it's going to decrease your motivation, you have abolition. So for both of these neural correlates, they're both to do with low levels of activity. But obviously one causes positive, one causes negative. But the point is that those parts of the brain aren't functioning on the same kind of level that they need to prevent those symptoms. Is there evidence to support neural correlates? Yes. Brain imaging techniques, it's very easy to establish relationships because we can see that we can do brain scans. It's an observable phenomenon. We can see activity levels, and we can say that people who experience auditory hallucinations are much more likely to demonstrate low levels of activity in that area. So therefore, there's a relationship between the two. So yes, there's credibility to this argument. Oh my god, my Mac battery's running out. Jesus. And then the problem is that correlation does not result in causation. So we might see that there is a relationship between parts of the brain, activity levels, and certain symptoms, but we don't know what's caused the other. So, for example, somebody might have low activity levels in their ventral striatum, which is causing them to lack motivation, or their lack of motivation is what is possibly causing there to be low levels of activity in that area. Because if you don't have motivation, what's that part of your brain needing to function for? So ultimately, there's evidence to support the idea that neural correlates play a key role, but we don't actually know. We just know there's a relationship. We don't know the actual key cause of schizophrenia, so it's not particularly useful in terms of an explanation. If a 16 mark comes up, then you need an extra deco. So like if you did neural correlates, that would be your first deco. If it was an 8 mark, you just do that. If it was dopamine hypothesis, an 8 mark, you would just do that. But if it was, and same for genetics, but if it was a 16, you'd need another deco. So generally the biological explanations are very useful because they provide evidence-based findings which are using scientific methodology, they are falsifiable. So the idea they can be replicated, other psychologists can repeat it and see whether their findings have credibility and confirm them or disprove them. And then you need to give an example that relates to whichever explanation you're talking about. So if it was the dopamine hypothesis, you can say the hypothesis is falsifiable. The psychologist can explain how they studied the role of dopamine, and then other psychologists could repeat that and confirm that dopamine does play a key role or falsify it. And obviously, this idea that it's falsifiable means that there's credibility, stands up to scientific rigor, or your argument is that by identifying a key kind of causal relationship, or a key correlation, if we know that these things exist, then it allows treatments to be developed. So if we know dopamine plays a key role, we can help the development of antipsychotic drugs to reduce that problem. Limitation is they're reductionist, they're only focusing on one level of explanation, so they're only looking at the biological role. There are other factors that they need to consider, so it's not kind of a holistic explanation, and that you need to say like why it's a limitation. So don't just explain that, oh, environmental factors can cause it, be like that's a problem because the biological approach kind of doesn't account for the fact that there are more factors to be considered. So it's not fully holistic. It doesn't kind of answer all questions in terms of how schizophrenia develops. And in terms of an overall, you can say like it is useful. It may not explain like all the different factors, but it gives us a very kind of strong insight into one specific factor that clearly plays a significant role in the development. Okay, so biological treatments. So we've got typical antipsychotics. They work by blocking the D2 receptors, so that prevents too much dopamine going into the postsynaptic cleft. So it will help the patient stabilize their dopamine levels, so they go from being in a hyper dopaminergic state to a kind of leveled, the correct stable level of diagnosis. How effective are they? So essentially there is research to say that they're much more likely to reduce positive symptoms than patients who were given a placebo drug, so showing that they are effective. But a problem is that they cannot reduce the negative symptoms of schizophrenia. So they reduce symptoms in those suffering from hyperdopaminergia, so they reduce positive symptoms, however they do not reduce the negative symptoms associated with hypodopaminergia. Overall, the effectiveness is dependent on the type of symptoms that the patient is suffering from. And obviously, if you were to do like a 16 mark on biological treatment, you would need to do that outline first and then that DET code first, or this evaluation point doesn't make sense. That evaluation point needs to come before you start talking about atypical, because obviously the point of atypical is that they do deal with negative. So the key thing here is that they operate by using multi-receptor action. So there's not just one, what do they call it? I can't remember the name for it. Completely forgotten. It's gone. I ain't got time to Google it. One attachment. They don't only fit one receptor, they fit multiple ones. So that means that they can stabilize the level of different neurotransmitters, and then that indirectly stabilizes the dopamine levels or increases dopamine levels for those suffering from hypodopaminergia. So multi-receptor action allows them to help patients that have got negative and positive symptoms of schizophrenia. So how effective are they? So they're more effective because they tackle both types, and it was effective in 50% of cases where the typical had failed. So much more effective levels. However, there are side effects still, and then the key thing here is that because there are side effects, patients are deterred from taking their medication. So patients choose not to take it because of their side effects. So obviously they're not going to be effective if patients don't take them. So how effective are they? Ultimately, when patients take them, they are effective. But maybe more research needs to be done to develop drugs which have less side effects. Is drug therapy the best form of treatment? So trials have shown that the drugs are effective in reducing symptoms in 2/3 of cases. So yes, highly effective. However, there's still a third that aren't responding to them. So therefore, supplementary treatments might be required. And then you can explain, like, they might need CBT, etc. It may be that the dopamine levels weren't the cause for those specific patients. Overall, in the majority of cases, it is effective, so it's definitely worth trialing this as a treatment to see the impact on sufferers. Psychological explanations. So psychological are divided into two categories. So you've got the family dysfunction, so they are the psychodynamic, and then you've got abnormal cognition, which is the cognitive approach. Schizophrenic mother. So From Reichman says that the mother essentially causes schizophrenia in her children by her parenting techniques, so overprotective, controlling, inconsistent, delusional in their behaviour, causes children to become distrustful, resentful, feel rejected, and the way they escape from this kind of confusing and toxic environment is by having hallucinations. So they split off from the reality. So the key thing to say, like in terms of explanations, you always have to say what symptoms it would lead to. So this leads to symptoms such as hallucinations because the child splits from reality and experiences hallucinations almost as a coping mechanism to deal with the toxic environment. Or you can say, like, the mother was delusional, so also the child begins to believe those delusions and also suffers from kind of false beliefs. Expressed emotion, so this is to do with communication levels, and it's about the level of expressed emotion. So you can have very low levels of expressed emotion. So essentially someone doesn't express any emotions towards you, so being very hostile, not kind of engaging with you, feeling very neglected, unloved, etc. Or the opposite side of the spectrum is that they overly express emotions, so very over-involved, overprotective, maybe like highly critical, etc. And this causes relapses in patients rather than being the initial cause of schizophrenia. So this is more related to triggering relapses rather than being the initial development. Double bind theory, so contradictory, confusing messages. Children are very confused about how to act. They think they've done something wrong. They're confused about if they're going to receive a punishment, how they can redeem themselves if they've done something wrong. And this results in them not being able to create an accurate perception of reality. So then that can result in symptoms such as paranoia or delusions. Oh my God. Sorry. Sorry. TV just started playing the football results. Where were we? So the symptoms that they develop as a result. So as a result of the confusion and the inconsistency, they develop delusions, incoherent thinking and speaking, etc. Is there evidence to support the family dysfunction explanation? Yes, there is. 69% of inpatients experience severe abuse as children, so showing that toxic environments are linked to development of schizophrenia. However, it's very difficult to actually identify what's meant by schizophrenic parenting. Childhood trauma is a lot more broad than that. It could be things such as a death of a parent. Oh my God. Queen's Park 2, Inverness. Sorry, just turn it off. It's much more broader than that. So essentially, there is evidence to support that there's a link, but it's quite vague as to what the actual triggers could be in your overall. Can mothers really be schizophrenic? So 76% had an insecure resistant attachment with their mother, and likely to report double binding statements in their childhood. So making sure you're kind of referring to both of the explanations there. In terms of your discussion point, I'd probably say like psychologists have discussed how significant the role of parenting is in the development of schizophrenia. So psychologists have discussed how significant the parent's role is in the development of schizophrenia. So then we're saying, yes, it is significant because there's such a high level of patients that say that they had kind of negative relationships with their children, with their parents. And then the issue is, there's two different issues here. So we've got, firstly, that it's socially sensitive. So it's problematic. It's blaming women for the disorders their children have. And there are lots of other factors that could have contributed to that disorder, but women are facing kind of the blame from psychiatrists, etc. So that's socially sensitive, and then also that is actually gender bias as well, because of the gender bias element is that they're focusing on the mothers. There's little research being conducted on fathers, so they should look more broadly into the role of parenting rather than mothers. But also the other issue here is this idea of determinism. So it's too deterministic to suggest that by having a schizophrenic mother, you're going to develop schizophrenia. So childhood abuse might be related to schizophrenia, but the majority of people who experience abuse do not develop schizophrenia. So therefore, the role of parenting, the role parents play, has kind of been overestimated by psychologists, and it's unhelpful for them to place kind of this level of responsibility on parents. Here we go, everybody's favourite. Okay, so dysfunctional thought processing. So the cognitive approach obviously looks at mental processes, and when they're explaining schizophrenia, they're arguing that there are dysfunctions in the thought processes of those with schizophrenia. So there are two separate explanations. So we've got dysfunction in meta-representation. So meta-representation is kind of your ability to put yourself in the shoes of another person. So can you imagine what another person is thinking or not? So the ability to kind of distinguish between what my thoughts are, what my knowledge is, and what their knowledge is. And if a person has dysfunction in this area, they might be unable to distinguish between their own thoughts and something that's actually happening. So like, is that voice in my head or is it external? Is someone else speaking? And delusions, etc. And unable to kind of understand the actions of another person because they lack the ability to fully understand that another person would have different knowledge to them. Okay, supporting evidence. So the Sally Ann test is supporting evidence to demonstrate. So, sorry, let me restart. There is supporting evidence, and the evidence comes from the results of research that psychologists have conducted using the Sally-Ann test to demonstrate that people who have schizophrenia lack the ability to meta-represent. So this piece of paper was given to people with schizophrenia, people without schizophrenia. The people without schizophrenia, 100% of them passed the test. They know the answer. But people who have schizophrenia don't pass the test. So essentially, the people with schizophrenia think Sally will look in the box because that's where the ball is. So people with schizophrenia lack the ability to put themselves in the shoes of Sally, to meta-represent in terms of understanding what Sally is thinking. So if they lack that ability, that demonstrates, if they fail this test, that demonstrates that there is a dysfunction in their cognitive processing. So in terms of the DECO, you're just saying this. So the Sally-Ann test requires the ability to meta-represent. People with schizophrenia are unable to pass this test. Therefore, that demonstrates that dysfunction or cognitive processing plays a key role in the development of schizophrenia. Is highly strongly associated with schizophrenia, let's say that. Correlation does not show causation. So just because we know there may be poor cognition levels, we don't know if that's the cause or the effect of schizophrenia. So is there dysfunction in meta-representation because they have schizophrenia, or is that what caused their schizophrenia? It's not clear. So in terms of your overall, you can just say like overall, whilst we understand it's a central part of the disorder, at this at the current stage of psychological research, it's not that clear how significant this is in developing the disorder. Dysfunction of the central control. So this is to do with the ability to suppress automatic associations that you might have whilst you're doing something else. So it's kind of to do, well, I'll not say that actually, I don't want to confuse you. So let's just stick with what it says. So, for example, someone might be speaking and you might have automatic word associations, and then if you're unable to suppress those, then obviously you can't finish your sentence. So word salad, disorganised speech, etc. could be associated with the inability to suppress those responses. Is there supporting evidence? Yes, there is supporting evidence. So psychologists have conducted the Stroop test with schizophrenic and non-schizophrenic individuals. Those with the disorder perform significantly worse on the test, therefore demonstrating that schizophrenia is associated with dysfunction in the central control. And then obviously you've got the same evaluation point as above, the idea that it's not necessarily explaining, it's just describing. But also you can make, and then this would apply to both, the idea that it only explains the positive symptoms. So it's only looking at disorganised speech and hallucinations and delusions. It's not looking at things like avolition, for example. So it only explains certain symptoms of the disorder. But if you get a question that just says like, outline one criticism of cognitive explanations of schizophrenia, don't use that point, just because there are cognitive explanations of the negative symptoms, but you don't need to know them for the spec. But there are cognitive ones that explain the negative symptoms. So if you just had a 2-mark that just asked you to evaluate, then I wouldn't use that point, because, or if you do, you would say like cognitive explanations such as can only, because if not, your evaluation point doesn't actually work generically. It only works for these specific explanations, so you need to state which explanation you're talking about if you do say that. But generally, it's obviously completely fine if it was an outline and evaluate, because when you've outlined it, you can then evaluate it. But just 1 year it came up as like a 2 mark just to evaluate it, and I thought, I bet people have written that, and that's not actually a valid criticism across the board of cognitive explanations, because some do, but you don't need to know them. Okay, psychological treatment. So CBT, so obviously cognitive behavioural therapy. 2 models, so this idea put forward by Beck. So the behavioural issues stem from faulty thinking, and the purpose of CBT is to help patients understand that they are having delusions or hallucinations, etc., and then provide them with strategies to kind of manage those. So one of them is reality testing. So essentially, if a patient says they have this belief, or they have seen something that you know isn't real, etc., you say demonstrate that. And then obviously when they can't, you can explain to them that, although you may be able to see a cat standing there, that's not actually there, that's just in your head. Or you may believe you have the power to fly, but you don't. But, you prove that to them, so then that helps them kind of develop more accurate beliefs in the situation. Ellis, the ABCDE model. So obviously the key thing you need to focus on is the D and the E. So don't spend loads of time explaining what the ABC is, but there's an activating event, for example, a hallucination. They believe that it's real. The consequences are that they they talk back to the voice or whatever it is. The dispute, the therapist challenges the beliefs, and then when they're exposed as faulty and the patient understands they're faulty, they can help them develop effective new beliefs. For example, that what they're seeing is part of their imagination, etc. Is CBT effective? So the NICE review found that it significantly reduces chances of relapse. However, it could be problematic in terms of forming a trustworthy relationship with the therapist. Obviously, they may feel kind of humiliated, doubted, etc. So it can be difficult to form positive relationships. And then you've got another additional one that we can use there. Family therapy. So Faro's your psychologist. I try and remember that because it's a bit sort of basic what this one is saying. So he adds a bit of kind of weight to your answer. So obviously families can play a key role in the development of the disorder, but not necessarily something that's problematic. Not necessarily something that's their fault. And also recognising that if families can cause it, then also they can play a key role in kind of rectifying kind of what they've done. So different aims, but essentially allowing the family to work together to deal with the actual issues. Faro did a meta-analysis and found that it significantly reduced relapse rates and was effective in kind of helping all members of the family cope with the situation. However, the problem is that if 69% of individuals are reporting abuse as a child from their family members, then it's going to be highly triggering experience. They're not the people to be having in a therapy session with you. So ultimately, whilst it may be effective, in some families, it's highly kind of dependent on the specific case of the individual and their past experiences with the family members. So it kind of only should be used on a case-by-case basis. It's not like a widespread, always effective, universal treatment that should be like a go-to method. So you might say like not as widespreadly used not as widely used as drug therapy. Psychological management techniques. So this is not a treatment, it's a management technique, which is obviously different. So if you get a question about treatments, don't use token economies because it ain't a treatment. Key things to get in your outline. It's based on the behaviourist approach. It uses the principles of operant conditioning, specifically positive reinforcement. It's aiming to deal with the negative symptoms of schizophrenia. So when people are suffering from things like avolition, they may lack motivation to do something, but if they are given a reward, it might increase the chances of them doing it. So if an individual struggles to have a shower, you give them a reward of watching a film in the evening. That increases the likelihood that they will repeat their desirable behaviour, reducing the kind of impact of their negative symptoms. I would always say give examples. So give an example of having a shower. Give an example of the reward. Refer to operant conditioning, positive reinforcement. Increase the likelihood of desirable behaviours. Are they effective? Yes, research shows that they are effective. There's a clear increase in the number of chores, etc., that they will do, and improved relationship between staff and patients in institutions. A problem is they're only effective for people with milder symptoms. Those with the most severe symptoms are unable to perform the behaviours. So obviously, if somebody has severe avolition, then they don't have the capacity to recognise the well, not to recognise, that's not the right word. They're not going to be motivated. Like, giving someone a reward is based on the assumption that people have motivation to achieve that reward. So it's kind of counterproductive to suggest that somebody is going to want to complete the task for a reward when they are lacking motivation. So overall, yes, they're effective in most cases, but may be seen as insensitive to the most severely ill. Are psychological treatments and management techniques useful? Yes, because they provide them with specific strategies, and it helps them kind of manage like those learned behaviours when they leave the institution, might help them in terms of actually functioning on a more independent level. Problem is that you could say that once they leave an institution, that they wouldn't be receiving the rewards anymore. So if they hadn't fully learned the behaviour, then it would abandon everything that they'd learned, essentially. So therefore, they would fall back into old behaviours and their symptoms would become overwhelming again. It's a lengthy process, obviously. It can take months, not a month, to have an impact. Often drug therapy is required to help stabilise patients. So in terms of this idea that the most severely ill are going to benefit, so they require drug therapy initially. So overall, they may be effective within institutions, but actually have limited use once patients are back in the community. And who is the person I was going to say? I can't find it. Oh, yeah, you can use Terrier as well and say, like, the idea that more than one treatment is often required. So a person isn't going to respond just to one, like, minor management technique. They need, like, more than one treatment method if they're actually going to overcome symptoms. Anyway, interactionist explanations. So obviously you need to say in this what it is that's interacting. So 2 levels of explanation, 2 factors are interacting. So the biological and the psychological or social factors. So biological factors are things to do with genetic vulnerability, neurological chemicals and structures and activity levels. And then also psychological and social factors usually are to do with family relationships, but we will look at kind of other levels later. So originally the diathesis stress model was put forward by Meehl back in 1962. And he argued that you needed both elements, so a genetic vulnerability and an environmental trigger, in order to develop the disorder. In terms of the genetic vulnerability, at the time he referred to that as the schizogene. Lol to the political correctness, but yeah, so as in he thought it was one gene and you, well, one code, then you needed to have that, and then you would develop a disorder if you experience the environmental stressor. So that would mean no matter how abusive or whatever your childhood was, if you didn't have the schizogene, you wouldn't develop the disorder. Also, if you had the genetic vulnerability but had a kind of a seamless life or no significant stresses, then you would again not develop the disorder. So just explain that briefly, and then you would do this deco. So Tinari provides evidence, so looking at different combinations of people with family histories of schizophrenia and then adopted into families with or without schizophrenia. He found that the combination of the two would result in you being most likely to develop the disorder. People always ask me what Finnish mothers mean. Mothers means Finnish is like they're from Finland. But then Meehl's argument lacked credibility because he used the term schizogene, implying that there was one specific gene, whereas there are actually 108 different candidate genes associated with the disorder. So it's much more complex than Meehl initially suggested. And then you can be like, overall, there's evidence to support the idea of the interaction, but psychologists had to revise the understanding of what is meant by diathesis and stress. And then you move on to introducing it. So more recent models have suggested that it's a lot more complex. There's a lot more different factors. So in terms of what actually could be the biological element, obviously we've got the idea that there's a lot more genes involved and other biological structures in terms of brain structure and neurotransmitters that play a key role. And in terms of the stressor, there's lots of different things. So high pressure jobs, bereavements, etc., could be the trigger. And drug use. So psychosis inducing drugs could also be an environmental trigger. And what was the other thing? Oh, also this idea that, again, there's kind of even more significant interactions between biological and environmental issues. So people who experience high early childhood trauma affect, like abuse can affect the development of their amygdala. So people who have experienced childhood abuse, brain scans have shown a smaller volume amygdala. So therefore, brain structures and brain development isn't genetic necessarily, it can be environmental. So that can be what could be described as the diathesis, because it's the biological element, because it's to do with your brain, could actually be caused. It doesn't necessarily have to be genetic, like that could have happened during your lifetime due to like neuroplasticity, etc. So yeah, essentially your point is there's a revised understanding, it's more complex than initially thought. The diathesis isn't necessarily genetic. Brain structures can change during childhood, for example, children who have experienced abuse have a smaller volume amygdala, and that would potentially mean they were more vulnerable to the development of schizophrenia. And then also you can say that there are other biological factors included, such as dopamine levels. Furthermore, there's been developments to how we understand what is meant by an environmental stressor. It's not just family dysfunction, it's also bereavements, high pressure jobs, drug use, etc. Is there evidence to support this model? And then we've got the idea of brain scans can support it. They can show the specific changes in the brain. So therefore, providing like falsifiable evidence, scientific credibility to this argument, because we can see from the brain scans that there is a change in their brain structure. Problem is it's too holistic. It considers obviously more than one level of explanation. It's much more difficult to establish cause and effect relationships and isolate specific variables to test them. So especially with the more revised model, it's much more difficult to see like what actually is causing schizophrenia, because when you're looking at it where there's lots of people that have the disorder and you're trying to decide kind of how they had it, how they mainly developed it, if there's lots of different things like bullying, etc., that could be contributing to it, it's much more difficult to isolate the specific cause. And then in terms of your overall, you could say, well, that kind of is the point almost, that it's a highly complex disorder. So actually you're not really trying to isolate one specific cause, because there needs to be lots of different things considered and the relative impact of all of those things. Or you might say that it's kind of problematic if you can't isolate a cause, then it makes it much harder to determine what treatment would be most effective. So does that depends on what you think. Interactionist treatments. So in terms of your outline, you're basically saying that interactionist treatments, the approach to treatments is that it takes more than one form. So they often want to deal with the biological element as well as dealing with psychological factors. For example, a person may take antipsychotics as well as receiving CBT. And then if it's a 16 mark on this, then just think, right, I need like 2 marks explaining what the interactionist approach to treatment is. So the idea that they recognise that the 2 levels interact, both play a key role in the development of the disorder. People who have it have experienced both biological vulnerability and an environmental stressor, therefore the treatment needs to deal with both. Then you would say like they would have CBT to deal with this, and then like I think you need 2 marks out of explaining CBT, kind of what it is and why that deals with the psychological aspect, or family therapy, whichever one you want to do. And then 2 marks for antipsychotics. So just think of it like that in terms of mark allocation, that you need to explain the 2 types of therapy that they're using in conjunction. So the 2 deck codes are to do with effectiveness, so just phrase them maybe in slightly different ways. So the first one is, so Terrier did research on different types of treatments, and basically people who were receiving 2 types of treatments, so CBT and drug therapy in conjunction, were more likely to see a reduction in their symptoms than those who were just taking antipsychotic drugs. So therefore suggesting that an interactionist approach is more likely to help sufferers reduce their symptoms. And then a problem is that often psychologists become misled that if interactionist treatments work, that means that the diathesis stress model is a valid explanation for schizophrenia. But actually what's happening there is the treatment causation fallacy. So that means that just because you're having drug therapy and family therapy, for example, and your treatment is showing a reduction in your symptoms, that doesn't mean that the interactionist explanation can account for the specific cause. It doesn't mean that there were both biological and environmental triggers to your disorder. It might mean that it was to do with childhood abuse, but by taking the drugs, you're more likely to engage in the therapy, for example. So, yeah, essentially, psychologists become misled. So then you could say, like, overall, ultimately, as long as the symptoms are reducing, it's not like hugely significant whether the psychologist knows what the actual cause was, as long as the symptoms are being addressed as a result. So yeah, overall, as long as the symptoms are being managed, it's not hugely significant that the patient understands what the key cause of their behaviour was, key cause of their disorder was. Secondly, so in this one, I might maybe rephrase it to be like, is using two types of treatment, or is a holistic approach to treatment always appropriate? So essentially, because they're taking a holistic approach, they're addressing lots of different factors that contribute to the disorder. So again, it's this idea that it's highly complex. If somebody has experienced trauma and has imbalances in terms of their neurochemistry, then they need to do things that are going to address both aspects. So a multi-action approach will allow different symptoms to be tackled. So therefore, obviously, it is the most appropriate. And then the problems associated. So if someone's receiving 2 or more treatments, it becomes difficult to identify which are the most effective. And also it's obviously very cost ineffective to give them more than one type of treatment. And then obviously if a patient becomes stable and you remove a type of treatment, then obviously you risk a relapse. So in terms of an overall, you could say like it might be more effective to consider giving them one type of treatment and then add an additional treatment if one isn't working independently, rather than trying to from the outset, so that it's easier to identify like which is most effective. Or you could say that like overall in an ideal world this would be the case, but in a kind of underfunded NHS and extortionate prices of private healthcare, this is not realistic. So psychologists do need to determine what the most significant factor was in that individual's disorder in order to treat them effectively. Oh my god, I'm exhausted. Hopefully that was helpful for you. See you later.